and welcome to another episode of Vital Times, the podcast. I am your host, Rita Agarwal. Today, I'm joined by two wonderful guests, and we are going to talk about climate change and what anesthesiologists and other healthcare professionals can do about it. Climate change is one of the defining challenges of our time, with far-reaching implications. There's evidence of increasing numbers of directly heat-related deaths in the US, but even more so across the globe. And that doesn't include deaths that are related to the consequences of climate change, such as the more profound and extreme weather changes that we're seeing, rising sea levels, disruptions in the ecosystem and agriculture, and famine. Addressing climate change involves action at the local, national, and global levels, but it includes the efforts of individuals, society, businesses, governments, healthcare, and other institutions. My two guests are individuals who are committed to addressing efforts to reduce greenhouse gases at the individual, institutional, and local levels. They are both anesthesiologists, and that is often where their focus is. I am really excited to be joined by Drs. Carol Lynn and Drs. Forbes McGain. Dr. McGain is an MBBS and PhD who practices anesthesia and intensive care at Western Health St. Albans, Victoria in Australia, and is the Associate Dean of Sustainable Healthcare at the University of Melbourne. Dr. McGain has spoken and published extensively, over 100 articles, on the topic of greenhouse gases, reducing carbon footprint, and bringing the scientific method to comparing the environmental impact of different practices. In fact, it was as a result of an editorial that he and Drs. Gordon and Chatterjee, and a presentation from my other guest, Dr. Carol Lynn, wrote that actually led me to finally, after 30 years, stop using nitrous oxide. I swore I would never stop using nitrous for my mass conductions, and I justified it by saying, oh, it's really brief. But I was convinced, and I hope that others will be convinced to try and make changes in their practices as well. As I put it, I'd given up DES, I had embraced low flow, I was minimizing volatile agents, but I truly thought you would have to pry nitrous oxide out of my cold, dead hands before I stopped using it. But they convinced me otherwise. My next guest is Dr. Carol Lynn. She's an associate professor of anesthesiology. Sorry, I have to look at my phone. At Associate Professor of Anesthesiology at Stanford University. She leads perioperative sustainability at Lucile Packard Children's Hospital and Stanford Children's, and founded the AWISH program targeting medical waste, and is the chair of the California Society of Anesthesiologists Sustainability Committee. Welcome to both of you. I'm going to start with Carol. First, I'm going to ask her what AWISH is, and then I'm going to ask her why she thinks sustainability practices, and in particular, sustainability practices in healthcare are important. Unfortunately, we were having trouble getting Carol on the podcast platform, so she is on the phone. So, Carol.
Hi, Rita. Yes, and hi, Forbes. I'm a big fan of Forbes, co-patriot with Diane, and good friends with Dr. Chatterjee. So the sustainability world is small, but growing and growing and growing. So AWISH actually stands for Addressing World Inequity via Sustainable Healthcare. It is a medical waste reduction program that focuses on 3 waste stream reductions: recycling, repurposing, and reuse, and donation. But in its heart, it's a volunteer group that is a sorting workforce that also really works towards the donation side of the medical waste reduction, which also addresses global health. Oh my goodness. Okay. And I will answer your question in just a bit. Okay, so So why is sustainability in anesthesia important? Well, it's important from a personal aspect. I'm a mother, and I want my kids to have a really positive future for their life. I want them to be growing up in a good, clean environment. But as a pediatric anesthesiologist, I also want a healthy environment for my patients because that leads to a healthier outcome, good patient outcomes. And we know that the environment and health is linked intricately. So it's very important that we as healthcare practitioners actually do less harm to environment and do less harm to our patients at the same time. And it's another reason why sustainable practices are very important for anesthesia is that I'm part of a healthcare system that's enormously wasteful. We are poisoning the environment, but we're also wasting a lot of economic dollars. And it is a well-known fact. There's lots of research out there, and Forbes is part of that research that shows that sustainable practice changes can lead to economic, sustainability, cost reduction benefits to the healthcare system. So those are my really big reasons for why I feel that we should be paying attention to this.
Dr. McGain, what inspired you to focus your research on sustainability within anesthesia?
Thank you very much for the question, Dr. Agarwal, and for the invitation. And hello to Carol. I think it was I actually grew up on a farm in northern New South Wales in Australia. I think being on a farm, you discovered that you didn't waste things. It was something that was just inherited. It was in the genes, in a sense. I learned from my parents. And so for me to suddenly then be thrown into medicine and see the large amount of waste, I think was quite disconcerting. I remember talking to my dad about, just as an example, Dr. Agarwal, metalware, single-use metalware, that you might to put a central line insertion in to someone's neck. When you think about the life cycle of that, it would be the iron ore would come out of Australia. It'd be sent to China. It'd be smelted there. It'd be then sent to Pakistan, interestingly enough, to Sialkot, an area there where a lot of metalware is used for producing surgical metalware. It's then sent back to Australia to me, and then I use it once and throw it away. And it's just quite ludicrous when you think about that life cycle.
You're talking about the needles used for the central line?
No, I'm talking about the actual metalware. In other words, the suture set. So the scissors and the forceps and the needle holders. Now, that's not the case. We've managed to rectify that in some cases in Australia, but still there's a lot of single-use metalware, as you know, and I still see that being used a lot in many high-income countries. And I think the other important thing is what Carol was alluding to there is the discrepancy between what you would see in low and middle income countries and high income countries is extreme, and it's just ridiculous, the waste that we produce. And look, as you know, there are various drivers for that, some of them being costs, but not always, because actually, as Carol was saying, what we've managed to do is show that you can actually make financial savings by having reusable metalware. But, there's also infection prevention. There's also the fact that single use has new toys all the time. And so it's just that process of working through what is possible to be reused instead of being thrown away. Thanks.
And the next few questions are actually going to be for you. So, because I know one of the things that has been traditionally very difficult is how do you compare one practice to another practice? And so I know one of the things that you've worked a lot on and have discussed a lot is life cycle assessment or life cycle analysis. Are those two the same thing?
Yeah.
Can you tell us what that is and what its relevance is to sustainability in healthcare?
Yeah. So in a nutshell, it's the environmental footprinting of a device or a process or clinical pathway, and that means measuring the carbon footprint associated with something, or how much petrochemicals are used, how much water is used, how much waste is produced, how much air pollution there might be. There's a whole series of different environmental footprints that would be so associated, for example, with any number of anaesthetic equipment you could look at, whether it be face masks, or laryngeal masks, or all those common things we know about. Now, but to do that is quite a process, at least in many circumstances. And I make a shout out to a number of people who've been involved in that, myself and Scott McAllister in Melbourne, Australia, but also to Professor Jodie Sherman in Yale in the United States, and Matt Eckelman with her, also to Cassie Thiel, who's based in Wisconsin. And so some really good work is happening in the US and beyond in this field. In order to do it, though, without just giving you the basics there, Dr. Agarwal, would be that you need to, at least initially, be working with someone who's knowledgeable in this area. It's like working, when you do a randomized controlled trial, it's probably wise to work with a statistician, because although I know a bit of stats, we'll always get advice on those sorts of things in intensive care, for example. And there's also a fair bit of software and packaging to do this properly if you want to publish in this field that's required. So there's sort of inventories or libraries of data that assist you in the process of working this out. That's it in a nutshell. Thanks.
And you already sort of addressed some of the parts of my next question, which was going to be how challenging is it to initiate research projects? And you've already implied that it's pretty challenging, particularly if you don't have mentors and support to do that.
But so what I would say is I think there's two caveats, I suppose, or positives about that. One is there are data now about quite a number of products, particularly in anaesthesia, because anaesthesia has been leading the way in this area within medicine for quite some time. And so there'll be data about reusable versus disposable equipment, for example, whether it be laryngeal masks or breathing circuits or any number of other common equipment. And so in other words, there's something in the literature there already. Also, there are I suppose, estimations of what it might be, and that's available. So this is not my work, but the work in the United Kingdom for the Centre for Sustainable Healthcare. They have small, like relatively short courses on carbon footprinting, which allows you to get an estimate of, what things might be that you use in your everyday practice, syringes and things. There's also, I suppose, work coming out of, Columbia University. There's courses you can attend, and there's, as I mentioned, the Healthcare LCA website, which is a Canadian-based website. Yeah. So there's a few good things coming out there that will assist those who want to get an estimation of, okay, I'm going to go down this pathway versus that pathway. And as you know, particularly for greenhouse gases, the desflurane and sevoflurane and nitrous oxide, that sort of information is pretty readily available now.
That's available now. So how would you identify a project that might be reasonable? I mean, how do you, what is or maybe I should ask it a different way. What is your next project? What are you going to look at next? I know you've spoken about and published a lot about the different gases, and you've talked about the source of electricity and when we're using, reusable versus disposable products, how you have to look at how those products are cleaned and how they're processed as part of the equation. It's not just what's going into the landfill.
Yeah, no, good question. There's a few things on the boil, as we'd say. I think one of the ones which is very low-hanging fruit is not so much life cycle, but more about what we learned from our environmental footprinting of the intensive care unit and also the operating room, in that the heating, ventilation, air conditioning that goes on in operating rooms, particularly when they're not in use, so setbacks out of hours, is really important. And I think anesthesiologists have a role in helping engineers to have, I suppose, the gravitas to change that. And as you know, so the requirement for the United States and many other countries is to have a minimum of 20 air changes an hour when an operating room is in use. In other words, every 3 minutes, the entire air volume is changed. Every 3 minutes. And so you imagine that's a lot of air moving. And the issue is that each operating room has its own ventilation air exchange. So it's sort of separate to the rest of the hospital. And so, as you'd imagine, if you're there in Palo Alto, in Stanford during the heat of summer, it might be, sorry, I can only work in Celsius. It would be, the mid to high 30s, maybe even higher at times. And then you've got to draw it down to 20. No, okay. Certainly I know that in Los Angeles it'd be higher.
Doesn't get that hot. Yeah. San Jose and inside in the valley can get that hot, but it's rare that we're much above the mid to upper 20s, even in the summer.
All right, if I take the whole of Los Angeles then, what I'm saying is that you might be, it's that difference in temperature that requires the energy, not so much the movement of air. So if you're drawing in air when it's really cold and you have to warm it up, like in Canada in winter, or you're drawing in air and you have to cool it down because it's really hot in Los Angeles in summer, all those things add to the energy use quite dramatically. And so you can very quickly, like an hour or two's use of the operating room energy could be equal to your house for the whole 24 hours. You know what I mean? So it's really important to think about that. The other work we're looking at is, I suppose, coming out of our anesthesiology paper where we compared knee replacements, spinal versus general anesthesia. It's really interesting to see the variation in practice between who has to wear a gown doing a single shot spinal. So in Australia, we have rules that you have to wear a reusable or disposable gown every time you do a spinal. But in the United States, you don't. So it's really interesting to start exploring those reasons. So for me, life cycle assessment is fascinating because it leads to the other stories that flow out of that from what you learn that you weren't expecting at all. And the other one, as you mentioned, was oxygen use. Like during spinal anesthesia, you might run 6 litres a minute rather than 1 litre per minute for general anesthesia. And that's got real environmental footprints associated. Yeah, wow. Lots of things.
Dr. Lin, did you have a question you wanted to ask too?
I just had a few thoughts on what Forbes is talking about. One of them was what you call the HVAC setbacks. Is that a lot of times what he's referring to is what we call low-hanging fruit that we can address in the operating room suite with energy use. From his paper, I looked that the bear hugger was a huge energy waster. And also the energy equipment that we use, we don't turn off. We don't have, motion sensor lights. Right. And of course, one of the biggest footprint is the HVAC, they call it setback. So that when we're not in the operating rooms, we can go as low as 4, I believe, refresh rates per hour, as opposed to Canada, maybe a little bit higher. Every country is a little bit higher, but these are easy, low-hanging fruits that the hospital can address very easily that, we don't even have to really think about.
So just for clarity, so what you're saying is that if we know we finished all the cases for the day, it's 5:00, let's say, and there's nothing else scheduled in that room until the next morning, if there was some way to automatically or reduce the air exchange rate from the 20 per hour to 4 per hour, that would be a huge, not only energy saving for the institution and potentially and a cost saving, but it's also better for the environment. Is that a summary of kind of what you guys were saying? I know you're more into the science of this than I am, so I just want to be sure I understood that correctly.
You nailed it beautifully.
Oh, okay.
Yeah.
Thank you.
And what I'd add briefly is, I've been very excited by what some places in the United States are doing in this field. So Massachusetts General Hospital, for example, is setbacks are just routine now for the operating rooms and beyond. So interesting discussions there. And once again, I think it's all about learning from others. And I think that unfortunately, there's pushback sometimes from various parts of the hospital say we couldn't possibly do that. But then when you benchmark with other high-end and look, it's like to say that low and middle income countries are not doing the right thing, because I think in many cases we could learn a lot from them. But in order to benchmark for infection prevention, it's nice to be able to say, well, look, Massachusetts General Hospital is doing this, and Vancouver General Hospital is doing this. I mean, infection prevention is happy there for this. So anyway, all good opportunities to learn from each other.
Yeah, and I think sometimes the concern about doing something that seems so drastically different than what we've been doing is concern that some organizing body, and I for example, our Joint Commission or some other group who may or may not be doing it at all, who may or may not care, but I think there is often this perception that they're going to care and they're going to ding us. We don't want to be dinged, because then that doesn't look good.
Yeah.
I got sort of off my Carol, Dr. Lynn, did you have, you said you had a couple of thoughts, and then I interrupted you with a question. Did you have any other thoughts before we go on to a slightly different topic?
I did want to revisit the life cycle assessment topic, because as I'm a fan of Dr. Forbes, I wanted to know, from a person who doesn't come from an extensive research or academic background, do you use, and I've taken the LCA SimPro based course.
What's LCA?
It's a life cycle assessment course.
Okay.
Give you an introduction to use a software called SimPro. And I found it incredibly time intensive. It did open my eyes to the concept of uncertainty in your life cycle assessment. But when I came down to it, even a project like changing a blue towel to a recyclable versus a more compostable material towel substitute, I found the process increasingly difficult and almost a barrier in itself. Do you have any advice? For example, have you reached out or collaborated with community non-academic physicians to answer these questions of sustainable projects, or do you use anything out there like Open LCA? Is that something that you've heard about that's public or free ways that people can access these LCA programs without having to pay a subscription, go through the rigorous academic exercise?
Yeah, big questions there. Thank you for that. So for those who are listening in, the SimPro is by Prey Consulting in the Netherlands, a software program that allows you to, actually develop a environmental footprint of something as simple as, a huck towel. That's what you call a bit of cotton, and try to compare a reusable versus a disposable variant of that. And then the other approach, which Carol was mentioning, was using Open LCA, another web-based platform, I suppose, which doesn't cost, it doesn't have license fee associated with it. I'll answer that question then in two parts. The first one is, when I first started, I, perhaps like you, Carol, was trying to do it myself. I was fortunate, well, I suppose serendipitously, I reached out to an expert in the area, and we were able to do a few projects ourselves and have ongoing with Scott McAllister, which is fantastic. And so that makes it a bit lucky in some ways, because they're a relatively small community of LCA experts, and particularly those who are interested or involved and engaged in healthcare in LCA. So what you can, I suppose, do if you think about, and look, this is something I think that increasingly will become important, is, I suppose, it's something I haven't got around to doing, or maybe, it's something we do want to do, I think, as a community, is look at some common things and consider what, are approximations to what the truth is, if you want to know. So in other words, if you have, and I'm not entirely sure what your question was, but if it was a reusable versus disposable cotton towel, for example, and if you're going to reuse the cotton towel versus and put it through the laundry system and then re-sterilize it, versus, say, recycling it. That's an example. And that can be as complex or as relatively simple as you want it to be, according to where you are in the world, what's your energy source. Is it a strict comparison one for one, or is it, do we actually end up wasting more on using two because they weren't as good as the other one? So you know what I mean? There's all these little added levels of complexity. But if you think it's just one for one, a reusable versus disposable one, I think you're probably right, we need a discussion point about this. That, say, cotton, for example, is just silly to be thrown away. Because it is such a high carbon footprint associated with the manufacture of cotton and the growing of cotton. You just shouldn't throw it away ever. And so the recycling of it is never as good. It's like, I can see Dr. Agarwal's white coat in the background. It'd be like her throwing it, or her clothing. You like throwing it away every day. I mean, it would just be, we just don't do that. So I think, those sorts of questions don't need ongoing life cycles. They just really obvious, but maybe they're one of those things we need to look at more carefully. I would point listeners to, Scott and I wrote an article in Intensive Care Medicine, reusable versus disposable. It's just an editorial. It's about 1,000 words, so it's out fairly recently. Just look out for our names, McGade and McAllister, Intensive Care Medicine, and that gives a little bit of a story there about some of these questions. But it's not the absolute. So we could talk for a long time, I know, about this, Carol, but that's probably all. I'll end it there. Thanks.
One of the questions I did want to ask, because I think for people who don't or who haven't had much experience thinking about these life cycle analyses, or how you approach deciding if it makes sense to make a particular change in practice in order to be more sustainable. Would you mind giving like an example and I'm just going to throw out, because I remember listening to a talk that you gave on disposables versus reusables, let's say supraglottic airways or endotracheal tubes, how you would look at that, and how I just remember being really struck by the fact that you are looking at things as in depth as, where does the power come from in this region? Where is the electricity? Is it coming from reusable sources, or is it coming from coal or something else that's dirty? So if you wouldn't mind and I know I promise you we will get you out at a reasonable time. I have a feeling both Carol and I are going to want to keep talking, but
that's okay.
We're not going to be able to. So if you could just a brief overview of how you do that and what you look at and what are the things that go into that process.
Yeah. And look, for listeners, I think probably for those who want to read a bit further, probably the most important one for me, but also I can list a few others. So once again, our work in the British Journal Anesthesia, reusable versus disposable anesthesia equipment. We looked at breathing circuits and laryngoscope blades and handles and face masks, and actually laryngeal masks, but also the anesthesiology spinal versus general anesthesia paper from a few years ago. And what I would say, absolute take-home message is where I live in Melbourne, Victoria in Australia, at least until recently, has been very coal-dominated for electricity. So perhaps like West Virginia, perhaps in the United States. And so that makes reusable equipment that require the electricity from that coal for washing and so disinfection and sterilisation, pretty hard to show that it's better from a carbon point of view than disposable equipment. But what I'm saying is that's probably the worst case scenario in the world. In other words, if you're in the United States, believe it or not, because even places like Texas have lots of wind and sun, and California very much so, or in Europe where there's a lot more hydro and nuclear, Canada where there's a lot of nuclear and hydro. So all those places, reusables are better. And there's probably no point, well, I mean, you're welcome to do it, Carol, but there's not a great deal of joy in repeating those studies of simple anesthesia equipment to show that they're better from a reusable point of view, because they will be better. So there are certain things we know now we don't necessarily need to keep doing the same sorts of studies there, because the take-home message is that renewables make reusables better. Renewable electricity makes reusable equipment better. And if you're, I think the tricky part is someone like China, which is incredibly important to the world. We need China to get onto renewables quickly, but they still have a lot of coal, some of it coming from Australia, that they need to move swiftly to a low carbon world, because, as you're probably aware, about half of all the carbon dioxide that's been emitted by humanity has happened since about 1990.
Since about when? I'm sorry.
1990. So that's a horrifying thought, isn't it? In other words, in the last 35 years, we've emitted as much carbon dioxide as the last 140 years.
Wow. I think Dr. Lin had one more question. Go ahead.
I love how Forbes is reaching out with the global perspective.
Yeah, I agree. I was going to say that too.
How we need to look at what other countries are doing. I've always looked at his operating rooms and the amount of reusables that he is able to accomplish in his operating theater is just amazing. And the data that he produces is very important, so that we can go back to our institutions and say, yes, look, they've done it. And we can do it too. And as he said, the benefit, you've done the hard work. You've shown the data to us to show that the benefits are there.
Yeah.
The key word now, circular supply chain or circular economy. Have you heard that, hot word passed around? And also, what are your thoughts on there is this, it's called the ESAIC Glasgow Declaration on Sustainability and Anesthesia. Sounds like a grand plan, some 3-year sustainability anesthesia, plan, roadmap, they call it, to increase the sustainability or decrease the carbon footprint, at least for European ICUs and anesthesia. Is Australia part of that?
Two parts to that question. So let me answer the first one. So circular economy, that's very important, and I suppose it's something that I've become more involved in the last year, and that I think that's thanks very much to Dr. Andrea McNeil, who's a surgeon here in Vancouver, Canada, and also Jody Sherman from Yale, United States. And I think that just having, for the listeners, it's that concept that you intuitively know about, that trying to reuse, reduce, recycle in that order, and most importantly, avoiding and reducing to make things more circular and reducing the footprint that we have on the earth. Now that there are 8 billion humans on the planet, all of us are going to have to tread more carefully and tread more lightly if we're really going to turn this mess, unfortunately, we've got ourselves in. So I think that's a really important lever to be using, and I think that we as anesthesiologists are moving ahead in that field, and I think it's quite exciting to see, Carol, even just in places like in Boston, seeing reusable gowns being used and things like that. So that was exciting, and certainly in Canada, that's quite common now. So they're all good news stories.
I'm old enough when that I remember that's all we used to have was reusable gowns. Then everything went disposable, and now it's nice to see that it's coming back. And sorry, I didn't mean to interrupt you.
No, that's okay. And sorry, Carol, what was the second part of the question? Yes.
The second question is, in the United States, we have this Biden climate healthcare pledge. And the European Union seems to have this AIC Glasgow Declaration of Sustainability and Anesthesia and for the ICUs. Australia, are they part of this? Do they have this climate?
Not exactly. Well, so this is for listeners, the European Society of Anaesthesia and Intensive Care in Glasgow, was it last year, and further been discussed in Berlin. No, not Berlin. Munich this year. So it's the plan to, for example, move towards total intravenous anesthesia, certainly to reduce death rate, and that's something that's from a little while ago, and reduce and cease the use of nitrous, as well as using more reusable equipment, for example. Is that present as a declaration in Australia and New Zealand? No, it's not a declaration, but I think that you're seeing this gradual movement at different levels, and I'd like to introduce here that whole concept of micro, meso, and macro levels of intervention that you as an anaesthetist, as an anesthesiologist, can do so much at a micro level by changing how much gas you're using and what type of gas, and whether you're using TEVA and how many syringes you're using, and any number of reusable equipment. But you move into that meso change, which is actually a lot of this stuff. Dr. Agarwal is important because it's, you can't really change to use reusable equipment if that's not what infection prevention or the central sterile supply department can cope with, et cetera, et cetera. So it's meso level, involves other humans and working together and collaborating and seeing what common ground there is to make change. And then there's that macro level, which is at the level of societies and colleges, as you described there, Carol, of the European Society of Anaesthesia and Intensive Care making declarations, or indeed the European Union making a decision to cease the use of desfrane throughout their nations in the next year or two. So there's whole levels of change, and all of them are important. We like to think in a way that, what about the government? Why doesn't the government do this? No, I think it's really important that we work on all levels, because in fact that what you're getting at there, Carol, is that decision by the European Society of Anaesthesia and Intensive Care it wasn't made in a vacuum. It was made with the knowledge that lots of anaesthesiologists had been working towards that for a decade. Of talking about CELO and desfrane and TIA and reusable equipment. It's that continuum from informing and reforming and then transforming the situation. So it's actually really exciting to see all these different levels going on as we move towards a more sustainable footing.
Yeah.
So I just want to switch a little bit and ask both of you, because we don't have that much more time left. I know Dr. McGaines has a hard stop coming up in a little bit. So I do want to ask both of you, actually, what are some of the biggest, or what are some of the more common challenges or barriers that you've had to deal with in trying to promote sustainability initiatives within your own practices or your own institutions? And I'm actually going to start with Carol, because we've had you talking a lot, Forbes. So,
thank you. I think one of the biggest challenges that's luckily we're making progress on is just education.
Yeah.
So, and I wanted to thank Forbes as part of educating myself. I used to think that sustainability in anesthesia was simply turning down the knob or changing my agent. But he really opened the curtain behind everything that we use in the supply chain. And it's incredible impact, as the supply chain is actually substantially more impactful on our carbon footprint than just our gases alone. So I found that education actually is one of the biggest barriers that we can address through talking about it, showcasing it in education, writing newsletters, producing data and research, just like he's doing. And that way people will, like yourselves, be motivated after 30 years plus of practice to stop the nitrous.
Stop the nitrous, man. Stop it.
Yeah, because we were educated through data, through talking. So that's what I think one of is the biggest barriers is the message, the education.
Dr. McGain, what do you think? What have been some of your challenges with this and barriers?
Yeah. I agree that perhaps it's like that concept of, like, even with education, I think it's how is that translated. And so, for example, I'm working with Dr. Jess Davies in Melbourne, and she's looking at the how we change. So I've always been interested in what do we know and how can we, what is the evidence base, I suppose. But then I'm well aware that the tricky part then is to how do you change people's behaviour. And Carol, in a way, you've talked about education as being important there, but it's not. It was quite subtle. It isn't just about education, is it? It's also you're chatting to other anesthesiologists and you're seeing what the peer group is doing, and you change associated with that as well. The sort of knowledge that other people are changing and what's going on here. I think that it's just very natural for humans to not work in a vacuum and to work together and to see what is the current modes and why they're changing. Absolutely, education is really important. Some data are really important to us as anesthesiologists. We're data-driven people, but I think it's also we're very human, and those sort of factors are important as well. The other barriers, Dr. Agarwal, particularly, I suppose you would say, I'll come up with infection prevention is a barrier. We just have to be aware that infection control and infection prevention is important to be aware of. And in all my studies, I've worked with them, realising that there are some things obviously we can't do about protecting the patient, and with the environment is something that we try to work within that system. But the patient is always first. However, providing high value care is actually about looking after the patient and the healthcare system. Because why does a patient want to have unnecessary blood taken from them for some pathology tests, some labs that you may never look at or are completely irrelevant? So do they really need to go for that CT scan, for example? So there's all those, do they need the operation? There's all those factors of high value care that I think are really important to say that also encompasses and includes good care with low carbon, low environmental footprint. So that's important. I think also there's industry. It's hard. Industry wants to sell single-use equipment because that's the paradigm. That's the modus operandi. And how do we, selling a smaller number of good quality reusable equipment is still a thing. It can be done. As we know, here I'm, in Canada at the moment and seeing what's going on, and reusable gowns, for example, being used there everywhere in the Vancouver General Hospital. Even the orthopaedic surgeons are using them. So it's really interesting to see how things can be done in different places with good, high-quality care as well.
I just want to say one thing. I find this really fascinating because, again, as I mentioned earlier, I'm old enough that I remember when reusable gowns were all we had. And I remember my surgeons kicking and screaming when we went to old disposables because they felt like these are cheaper quality and these are not as comfortable and they didn't like them. And there was a whole lot of resistance against that. And now it's all back. And then I also was really struck by something you said at the beginning about, you said infection control areas are often things that are barriers to sustainability because they will often mandate that you have single use. I remember, again, a few years ago, maybe longer than a few years ago, there was a real push to go towards single use laryngoscopes and single use, video laryngoscopes, which I think is actually what we are doing now. And we were sort of fighting and kicking and screaming against it, especially in our little children, because the profiles on some of these blades were a little high and it made it more difficult. And yet we know that from a sustainability point of view, that's not a great idea. And I suspect that we'll come back around to going to reusables again. The other thing I wanted to comment on Carol's education, she knows I say this all the time. She's like, well, what can we do? And I'm like, God, if we could just get our humans who are here and who know how to use these darn bins, because they've been using them forever, the recycle, compost, and landfill bins that are all over our hospital, if they could just use them correctly and put trash in the trash bin, recyclables in the recycle bin, and compostables in the compostables, that would be huge. But we can't even get people to do that some of the time. Okay, Carol, sorry, back to you.
I wanted to bring it out to not just to individuals' fault, because we talk about education. We talk about, I like how Forbes is saying that we look at it at many different levels. And one of the biggest levels, the macro level, I'd like to mention is I'd like to ask, what do you think about a proposal? Why don't we regulate the plastics and medical waste and supply like we do the oil industry? Plastics are essentially oil. The oil industry and the governments, they legislate it. They say, for this car, this has a rolling emission standards. First it was 20 miles per gallon, 50 miles per gallon. All cars must, increase their miles per gallon every year, their, efficiency. Perhaps we should look at the amount of plastics or even the amount of reusable supplies that a hospital uses as a moving target.
Yeah.
That's on the macro level. So
that's a great question.
I think that we have the larger conversation around that level. We don't put the burden on individuals. Just like we look at the burden of is it an individual's
and you raise a really good point
on industry burden?
And it relates to what Rita was also messaging about, in a way, the difficulty of recycling and how people find it difficult. And we sort of blame people for that because in the end, wouldn't it be interesting if the FDA said, there's a requirement for all manufacturers of single-use equipment, medical equipment, to say, well, why cannot this device be reusable? What is it that you think that makes this impossible to be reusable? Now, some devices are probably quite tricky, but in many cases, I don't know about that justification.
I think a lot of it, and you talk about the oil industry. I mean, let's not really, I don't want to get into the political stuff because a lot of this is money and political will, right? It takes time, it takes effort, it takes energy of all kinds, but a lot of it is money and influence, and it's not easy to do these things. We're coming up to the end of our time, so I kind of just want to finish up with. There's so many more questions I have, but and I would love to have you guys back at a future time, but when we can get all our technology working perfectly. What are some ongoing initiatives or projects that you're particularly excited about in anesthesia related to sustainability? And I'll start with you, Dr. McGain, and then I'll let Carol give the last word on that.
Thank you. So probably as this is not rocket science. So probably the most obvious low-hanging fruit is the heating, ventilation, air conditioning, working with engineers to do that. Now, the reason for that in particular is it saves money. It will save money. There's no doubt it will save money. It's just a matter of getting the coordination to do it. The other one is working with anesthesiologists to see, okay, we've moved to this level of, we're not really using nitrous anymore. We've actually decommissioned the use of nitrous in some hospitals in Australia, and that's happening more broadly. But we need to move on that because there's lots of leaks of nitrous oxide happening now. Or have always happened, but we weren't aware of. In other words, the nitrous that never makes it to the patient, the nitrous that's being wasted because of leaks in the pipeline system. So we're building a new hospital that will be the first hospital in Australia that will not have plumbed nitrous at all. Yes, it'll still be required on little wheelie frames and things like that, but that will also reduce the actual access to nitrous because people will have to purposely use it. That's more difficult, of course, in a maternity or birthing suites where it's more common in Australia. It's not so common in the United States for maternity, for birthing. But that's another big one. I'm working with anesthesiologists, Dr. Eugene Kayak, and others within the Australian and New Zealand community there. So that's nitrous is really excited about. And the other one that we're working on is, developing more of this inventory of equipment so that people like Carol will be able to, we want to make it an open source thing where you'll be able to more easily work out or do a little simple life cycle assessment of stuff that you might use. Now, I'm afraid, Carol, that's a few years down the track, that one. But along the way, we're going to be looking at oxygen use and, as I mentioned, some of the other energy savings. There's also things happening in intensive care, but they're the main things in anesthesiology. Cheers.
Great. Thank you so much. Carol, what are some things that are coming up that you're particularly excited about?
Well, now I'm very excited to see this easier life cycle assessment accessibility that Forbes is talking about. I hope it's incorporating AI. I'm sure it probably is, but I'm looking forward to that. I'd like to mention two things. One is partnerships with industry. That is something I see more and more institutions doing, or individuals. We're reaching out to different companies that specialize in sustainable anesthesia practices. For example, Stryker, they have a reprocessing. Stryker is a company in the US that's one of our major medical suppliers. They have a reprocessing program. And with just one high value item, such as a ligature, reprocessing in Santa Clara hospital systems, they can save almost $1 million. And wow, if they enroll in this whole program with about 10 to 12 different items, they will save definitely over $1 million for a large institution. So look at industry, outreach to industry, and partnership with industry. Another industry is Hall circuits, such as from Cytiva. But you can also just reach out to the major medical suppliers such as Medline, Cardinal, and see what alternate to plastics item.
That's a great idea. I love that.
And the second thing is, I am very excited for this project that I have presented within our School of Business and proposed within our hospital system and our Stanford system with grants. Hopefully, we're getting very close to getting our hands on the plasma resterilizer. This is a new technology, and for the United States, it's very exciting because the FDA just approved it as an established method for re-sterilization of medical equipment. It was designed for those high, complex, delicate equipment, such as scopes, robotic arms, but nobody's really explored the possibility of single-use items that are clean but unused, and their sterile packaging is broken. The FDA here in the United States is very tightly regulated in the hospital system, but I'm exploring the use of plasma re-sterilization for increasing the donation stream, because one of the barriers for global medical distribution is the fact that medical equipment needs to move from one country to the other in mostly sterile containers, sterile packaging, to avoid the infectious risk from spreading. So those are the two exciting innovations that I think that we should be exploring.
Well, thank you both so much. This was really both inspiring, and I'm excited to keep working with both of you. I will definitely try and have you back at a future date. And to our listeners, thank you for listening to another episode of the CSA's podcast, Vital Times, and I hope you'll join us in the future for another episode. Thank you.